for saying, Peter, how do you know your checklist couldn't have been 3 things, or 4 things, or 2 things, or 1 thing? Which one of those 5 is most important? You didn't test it. And my response was, you're absolutely right. Because my goal was to prevent deaths from infections as quick as I could. And if I studied each one individually, the study would still be going on, right? Because it would take a long time. And unless a component of an intervention is risky or costly, it's not worth knowing whether the checklist could have been 3 things or 4 things or 2 things, because none of them were that big of a deal, right? But what we've shown is that when you package an intervention that maximally will drive down infection rates or improve outcomes, you're much more likely to get a bigger impact than testing one little piece. And then I'd say, well, why aren't you doing this other piece with culture change? That's important. Oh, well, if I did that, I wouldn't be able to tell if this one thing worked. And I'd say, okay, well, is it really worth knowing that? So bottom line is healthcare has far too much mind, less variation. And it's, at least where I work, it's because of power, and it's not based on science, and that we have to reduce that and try to drive up mindful variation so we innovate more.
Now your checklist is now spread all over the United States and to some parts of Europe as well. Does it look the same everywhere? There is some variation, I know, but what's the point of that variation? And is it a good thing or a bad thing?
Yes, so that's a really important point, John. One of the key lessons that I think people need to understand is the difference between evidence-based practices and interventions to implement those practices. Right? And we often have this debate about whether you do a top-down, everybody uses the same guide checklist, or a bottom-up local development. And what I realized is that that's a false choice. What we ought to centralize is how to measure infection rates, because there is science to guide us, and you can't compare if you don't have a standard way to measure it. And we ought to summarize the evidence of how to reduce infections, because it's ridiculous that everybody spends their time looking up the same literature. But we're completely humble to say, but you need to vary how you implement that evidence locally. So the evidence-based practices are the 5. But the checklist is really a tool to help people implement them. And they all look different in all of these hospitals. Now, they're 99% the same, but that 1% difference is what makes it work in each of their hospitals. And every one of them is the best for their local environment, right? Because nothing would get it resisted more if I walked in as a manager and say, I want you to use this Johns Hopkins checklist, right? And you would say, no way, because there's really good data that external controls are highly resisted and often wrong by professionals. Rather, what we say is, here's an idea of some evidence-based practices that looks to work. Could you make it better? Make it fit your local hospital. And every one of these hospitals believes theirs is an improvement, and it is for them. I mean, it works for them, but mostly it's because they make it their own. Right? So I strongly discourage any hospital from using the Johns Hopkins version. It won't work. They have to put their own fingerprint on it. They have to make it their own and fit their local resources, their local culture. And I think that difference between what's an evidence-based practice and what's an intervention to implement that practice is a very key distinction.
Oh, yeah, so its ownership is very important. But what about ownership not within a hospital, but within different professions? You've been talking mainly from a doctor's perspective here, but nurses are also involved. Do they also feel ownership of this, and how do you commit the nurses to follow your checklist?
Yes, so great point. What we do, and again, it's novel for medicine, is when we're creating these interventions, what we ask hospitals to do is to invite anybody who touches the process to be part of the development. So it could be a technician, a nurse, a hospital administrator. Like I said in my speech, erase those lines, bring everybody in the room and say, what does it look like? So when we do these programs, we'll have the infection control doctors, the infection control nurses, the hospital safety administrators, the local ICU doctors and nurses all around the table. And what we say is we align them towards a common goal of reducing infections. And then we have a conversation about how best to do this. What does the checklist look like, and what each of their roles is going to be to achieve this goal. So yes, it has to be interdisciplinary.
So that's another point. It has to be interdisciplinary. That's one thing. But there's a great step from that to a team.
Right. Yeah, you're absolutely right. In medicine, we use the word team so often, but the reality is we're a team in name more than we are in function. If you look at attributes of high-performing teams, they cross-monitor, they support each other, they are able to flatten the hierarchy and question each other, and medicine doesn't do that very often. Indeed, it's interesting because if you look at where most of the safety literature has come from, it largely has come from intensive care units. I think it's like 80% of it. And so if you ask, why is that? Well, in intensive care units, there is a team, right? For the most part, they work with the same doctors and nurses. If you go to a medical surgical ward, right, there's no team. I mean, there's 50 different doctors admit there. The nurses don't know the doctors' names often. And so that we haven't created the structure to support a good teamwork, and I think we need to do that.
Okay, but one thing that really stops teams to develop is hierarchy. But at the same time, there's got to be some sort of hierarchy. When there are leaders, there's a question of different competencies and so on. So could you perhaps discuss that a little?
Yeah, you're absolutely right. So this notion that teams are always flat and are self-organizing is really just a myth. I mean, we need a management structure, and there has to be hierarchies. But what we need to do is to be able to flatten those hierarchies when somebody senses a risk. So, for example, on an aircraft carrier, a very low-level technician is able to call the senior commander if they sense there's a risk. So there's a classic story where there was a hammer left on a runway, and a technician waved off planes that were landing. It cost them literally, I don't know, hundreds of thousands of dollars in fuels, but that was rewarded. In healthcare, and you as a surgeon, and not saying your practice, but for many surgeons, if a tech or a scrub nurse in the operating room would question you about some risk, or I think you left a sponge in, or I think you did this, you'd probably be indignant, and say, how dare you question me? And so it's not that hierarchies are bad, it's you have to be able to flatten the hierarchy. Let me give you an example. I was in the intensive care unit tragically when 9/11 occurred. And as you know, a plane went into the Pentagon, and I was making rounds, and my hospital and myself got a phone call from the White House and said, empty your ICU now. Hopkins will be the receiving for people hurt in D.C. We don't know what's coming in. We need a safe place to send people. Empty your ICU. Now, I'm normally very team-oriented, with everyone's input, right? I had a mission, I had work to do, and I literally grabbed the charge nurse, went bed to bed to bed, and said, forget the residents. I mean, they were there, but that was very clear decision-making. You will do this patient's going here, because the urgency was so clear, right? Other times when I have time, we broadly get people's input, and if there's a conversation on rounds, and we need to do teamwork. Let me end with, or not end, but comment one other thing about teamwork. If you look at the science about how teams make wise decisions, and it's a very mature science, teams make wise decisions when they do two things. When they have diverse and independent input, so everyone has something to say and you don't just follow along because I said it's good and that you go along. And second, they alternate between what's called convergent and divergent thinking. That is, they may make a plan, but if they get data that disconfirms their belief, so patients' vital signs change, they pause and they go brainstorming again, divergent thinking about what's the diagnosis, right? In all those fields. So you think someone, did well after surgery, but their blood pressure's low and their blood, hemoglobin's low. You say, okay, maybe they're bleeding. Let's step back. What could be causing it? And if I think about how we could create those two attributes, one way is interdisciplinary rounds. So every day, bring the whole care team to make rounds. The second way is if ever you have a sick patient instead of communicating through consultants through the electronic record of the nephrologist says this, or the cardiologist says this, or the infectious disease, bring everybody to the patient's bedside together to get that collective brain power.